Kita niyo yung PowerPoint? Sorry.
Yes po.
Okay, thank you. Hey, Dr. Castillo po, and I'll be discussing topics on pain and temperature. So first, I would like to apologize, no? So due to um, technical errors, late na publish yung lecture for pain and temperature. But then, if you check your Canvas, it's already there, uploaded yesterday. So you can look back sa lecture sa uploaded sa Canvas. Okay? So I'll be discussing pain and temperature, and these are my learning objectives. So ito yung parts of my lecture. First, I will give a short review on the basics on pain. So yung sasama ko lang would be topics that I think na parang quintessential. Ibig sabihin, kailangan matandaan nyo. And then second part would be a case-based discussion or of usual pain um, painful conditions. And then third would be a review on the basics of temperature and its regulation. And fourth, I would be discussing a case regarding temperature dysregulation. Okay? So yung guide natin for our session, okay, wait guide for a session. So yung parts 1 and 3 would be, again, a review of the basics. Tapos may mga questions tayo doon. And you can answer through the chat function. Okay? And then you have 15 to 30 seconds to answer. Usually, madali naman yung mga questions na binigay ko. And then for parts 2 and 3, the discussion would be case-based. So ang focus ko would be practical application of some physiological concepts discussed in my lecture. Okay, so let's go to the first part, which is the basics on pain. So kung may mapipick up kayo sa lecture ko, dapat ito mapick up nyo talaga. So the anterolateral system. So this is a system that is composed of three tracks. So first, the spinothalamic tract. Ito yung nagki-carry ng signals for crude touch, pain, and temperature. Next would be the reticulothalamic tract or the spinothalamic tract. Yung paleo-spinothalamic tract, important naman siya for chronic pain, as I will be discussing later. Sorry. And then third would be the spinotectal tract. Yung importance naman nito would be with regard to spino-visual reflexes. So most probably this will be discussed in the optics part or visual uh, physiology. So ito ang talagang dapat yung ma-pick up from my lecture. So the spinothalamic tract is actually an ascending tract that is composed of two adjacent pathways. So you have the anterior pathway, which carries sensory input about crude touch, and the lateral pathway that carries information about pain and temperature. So this tract, so ascending nga siya, so paakyat, would start at the dorsal root ganglion. So yung DRG, siya yung nagre-represent ng first order neuron or or the afferent neuron of your spinothalamic tract. And then this first order neuron would enter the spinal cord through the lateral dorsal root entry zone to enter the to enter the Lisauer tract, and then would synapse with the second order neuron. So yung second order neuron natin, yung second order neuron natin would be at the substantia gelatinosa. Yung substantia gelatinosa is at the gray zone of your spinal cord. And then, as you can see here, dito sa baba, the tract would then cross across the spinal cord. So, ang term natin dito would be decussate. So, magde-decussate siya to the opposite sides about 2 segments above the level of entry via the anterior white commissure. And then, yung decussating second neuron fibers na nag-start from the substantia gelatinosa would then enter, go towards the up the spinal cord and would enter the brainstem as the spinal lemniscus. And then, yung third order neuron natin, this tract would terminate actually at the thalamus. Sa third order neuron natin which is the ventral posterolateral nucleus of the thalamus. So review lang natin. First order neuron is yung DRG, so dorsal root ganglion. Second order neuron is are the neurons at the substantia gelatinosa. And then third order neuron is at the level of your ventral posterolateral nucleus sa thalamus. Yung third order neuron natin would then would then project out laterally and somatotopially through the internal capsule and then would terminate at the post-central gyrus. So, sorry for the barking dog. At the primary somatosensory cortex. Okay? So, ulit, first order neuron, DRG. Second order neuron, substantia gelatinosa. Third order neuron, VPL at the thalamus. Okay? So, ito yung sasabi ko kanina na anterior part of your spinothalamic tract is involved in carrying information about crude touch, and then lateral would be involved in passing on information about pain and temperature. Okay. So pag sinabi nating somatotopic, anong ibig sabihin nun? So basically, somatotopic organization is just segmental organization involving input from the cervical, thoracic, lumbar, and sacral area of the body. So somatotopic organization means that the medial part, so as you can see here sa baba, the medial part of the tract would receive cervical input while the lateral part of the tract would receive the sacral input. Okay. Next. So punta tayo sa definition ng pain. So according to the International Association for the Study of Pain, or IASP, pain is an unpleasant sensory and emotional experience associated with or resembling that which is associated with actual or potential tissue damage. So basically ang ibig niya sabihin is pain does not only have as objective, physiologic, and sensory aspect, it also has a subjective, emotional, and psychological component. Okay? So first question, ito pwede niyo sagutin through the chat box. So first question would be, perceiving a non-noxious stimulus as being painful is called? Okay. Yung choices would be hyperalgesia, anesthesia dolorosa, allodynia, and hyperesthesia. Wow. Okay. Okay, so I've seen your answers. So most of you answered allodynia. So this is correct. Actually, simple lang naman kung paano gawin yung words sa medical field, di ba? So pinagsasama lang nila yung para may root words. So hyper, algesia, increased sensitivity to pain, hyperalgesia. Your hyperesthesia naman is increased. Esthesia is sensation. Increased sensitivity to sensation. Oo. after stimulation. So ano tong anesthesia dolorosa is actually an uncommon differentiation pain that can occur after trauma to that trigeminal nerve. So tama kayo, the answer is allodynia. So next. Okay. Okay. So again, review lang. Sabi ko nga, yung medical terms would be parang pagsasama ng mga root words. So, analgesia, anything na may an, nilalagyan ng an sa start would be absence. And then algesia, analgesia, so absence of pain. And this is without loss of sensation or loss of consciousness. And anesthesia, absence of physical sensation. Same with hyperalgesia and hypoalgesia. So it just means diminish and increase sensitivity to painful stimulus. And then hypo and hyper. Sabi ko nga, pag nakakita kayo ng anesthesia, ang keyword would be sensation. So sa exam, ganun. Kung makakita kayo ng algesia, ang hahanapin nyo na keyword dun sa choices would be about pain. And pag nakakita naman kayo ng aesthesia, ang choice na mas pipiliin nyo would be sensation. Paresthesia. Pag sinabing par, yung par is dysfunctional. So abnormal. Abnormal sensation without apparent stimulus. So examples niyan would be yung pins and needle sensation and numbness. And then neuralgia is basically just pain along the distribution of a nerve or a group of nerves. Okay, so this figure shows the difference between allodynia, hyperalgesia, and normal response to pain. So in allodynia, basically, non-painful stimulus or non-noxious stimulus would be perceived as painful. So supposedly no pain siya, pero in hyperalgesia, you feel it as pain. Example ng mga non-noxious na stimulus would be your touch. Ganun. While hyperalgesia means that the pain is being perceived stronger than the usual response to a given painful stimulus. Question 2. Which is incorrect about abnormal sensations? Or, dadagdag ko lang, or pain. So, A, dysesthesia is an abnormal sensation with or without stimulus. B, paresthesia is an abnormal sensation without stimulus. C, hyperalgesia is increased response to non-painful stimulus. D, hyperesthesia is heightened sensation in response to stimulation. So, what's your answer? Easy lang to. Very good. So most of you answered hyperalgesia. So very good. Kasi ano ang sabi ko kanina, pag nakakita kayo ng algesia, ibig sabihin maghahanap kayo ng pain. So hyperalgesia is increased response to a painful stimulus. How about yung other choices? Kasi pwede ko rin siyang ibigay sa exam. For example, dysesthesia, pag nilagyan mo ng dys in front of a root word, ibig sabihin abnormal din. So dysesthesia is abnormal sensation. Paresthesia, again, abnormal sensation without stimulus. And then hyperesthesia is, ano yung ibig sabihin ng esthesia ulit? Sensation. So increased heightened sensation in response to stimulation. Okay. Very good. Wait. Okay. Okay, ito. At what time frame does persistent pain become defined as chronic pain? Yung mga ganitong questions, di ba, kailangan nabasa mo yung lecture. Oo. So, A, 3 months. 2, 6 months. C, 9 months. D, 12 months. Sige nga, anong answer natin? Okay. Okay. So, ito. So, very good. The answer is letter B. Okay. 6 months. Okay. So, sabi ko nga kailangan nabasa nito. Ito, diniscuss ko actually ito sa asynchronous lecture ko. So, acute pain. So, masasabi natin na parang necessary evil yung acute pain eh. Kasi it's a protective mechanism that serves as parang alarm system ng katawan natin uh, with regards to a disease or threat to the body. So, pag acute pain, it's usually caused by injury, surgery, illness, or trauma. And yung characteristic ng pain, usually sharp siya. So, parang tumutusok. Ganun yung description nila. O kaya, and then the onset is usually sudden. Acute pain usually lasts for a few minutes to less than 6 months. Ito ay by the definition of your International Association for the Study of Pain. And usually, acute pain disappears when the underlying cause is treated. So, ang response for your acute pain would be activation of your sympathetic nervous system as summarized here sa table. Okay? So, alam na natin yan. Sabi ko nga kanina, yung pain does not only have physiological impact, meron din siyang psychological impact. So for acute pain, the psych impact would be fear, uneasiness, and anxiety. So as against your chronic pain. So pag sinabing chronic pain, it's long-standing. So at least 6 months yung pain. And yung pain niya would occur beyond the recovery time from any injury or surgery. Oo. And yung chronic pain usually would occur either persistently or intermittently. And yung psychological impact na implicated dun sa persistent and intermittent pain would vary. Kasi yung for the intermittent pain, the response would be similar to your acute pain. While your persistent chronic pain, yung person would already have normally body function, but the pain would persist. So, nag-a-adapt yung person. So, this can actually affect a person's quality of life. So, some patients with chronic pain would have hopelessness, depression, attempt to hide pain, preoccupation with his own pain, and sleeping disorders. Okay. Next question. So, which is not a systemic response to acute pain? A, hypertension. B, hyperventilation. C, urinary retention. D, increased peristalsis. Okay. Oh, easy lang yan. Very good. Okay. Okay. So, basically, kapag yung effect ng acute pain, di ba sabi nga natin, is activation of the sympathetic nervous system. So, para ma-answer niyo yung question na to, i-identify niyo lang which symptom would not be presented or would not be present in an activated sympathetic nervous system. Okay? So, easy lang yan. Next. Okay. So let's go to the elements of pain processing. So basically, may four parts ang pain processing. So, supposedly, para magka-pain, meron ka dapat source of noxious stimulus, which can be mechanical, chemical, or thermal. So for thermal source of noxious stimulus, it would be heat and cold. For mechanical, so injuries that can cause inflammation. And then for the chemical would be algogens. Ito yung mga painful na chemicals. May table sa asynchronous lecture ko, may table tayo doon of yung actions nitong algogens. So, isa sa pinakamasakit na algogen would be your bradykinin. And then other algogens would include serotonin, histamine, potassium ions, acid, acetylcholine, and proteolytic enzymes. Okay. And then meron ka rin dapat pain receptors. And yung interaction ng noxious stimulus and your receptor would lead to transduction. Transduction is basically when noxious stimuli are converted to action potential. Okay. Next part would be transmission. And then transmission is just the action potential being conducted through the nervous system through the release of chronoreceptive substance into the synaptic cleft. So again, may first, second, third order neurons. Ulitin ko lang, first order neuron, DRG. Second order neuron, substantia gelatinosa. Third order neuron, VPL thalamus. Tandaan niyo. Okay. And then perception of pain na napaprocess. Perception of pain is the final common pathway. It is the integration of painful input into the somatosensory and limbic cortex. So, yung involved na parts dyan of the brain would be your limbic system, your reticular formation, the thalamus, hypothalamus, and cortex. And finally, modulation of pain. So, modulation can be inhibitory or it can also cause augmentation of your pain. So it's at the level of, yung modulation natin is at the level of your dorsal horn and involves either spinal or supraspinal mechanism. Okay. So next question would be true or false? The nociceptor adapts very little and sometimes not at all. So, answer tayo sa chat box. Sige nga, sige nga. Parang konti yung sumasagot eh. Ang question ko, ang answer dito is true. True. Ang next question ko is bakit? Sige nga, kung may theory kayo, pwede nyo i-drop sa chat box. Kung may theory kayo, kung bakit non-adapting dapat. Ginawa ng universe na non-adapting ang nociceptors. Okay. Sige pa. Go. 30 seconds. Anong sabi natin kanina? Diba? Yes, ito, may nakita ako. So, if you, ito, to save ourselves, more of protective mechanism. Ayun. And then warning of potential potent damaging stimulus. So that we would know when to stop going through life-threatening pain. Okay. Okay. So ang answer dito, the answer dito is yung sinabi na natin kanina, because it allows the pain to keep the person aware na merong tissue damaging stimulus na nagpe-persist sa body. So important na yung nociceptor mo, yung parang non-adapting yung nature. Okay? Very good. Thank you for your answers. Okay. Next question tayo. The major excitatory neurotransmitter responsible for the transmission of first pain would be silang rin. Ano ba yung pinaka-talamak? Talamak na excitatory neurotransmitter sa katawan. Yun din yung major excitatory neurotransmitter responsible for transmission of first pain. Okay. So the answer is glutamate. Di ba? Yun yung major excitatory neurotransmitter of the body. Yun din yung primary responsible for the transmission of your first pain or your, pag sinabi mo kasing first pain, yun yung fast pain na tinatawag. Actually, discussed to sa lecture, sa asynchronous lecture ko. So, pero sinamarize ko rin para sa inyo for this section. So, fast pain versus slow pain pathway. Yung difference niyan, yung fast pain would be through the neospinothalamic pathway. And then, as against your slow pain na through your paleospinothalamic pathway. Kailan ko to nabanggit? Yung paleospinothalamic pathway kanina. Nabanggit ko to, no? So, isa siyang part ng anterolateral system. Yung other term for this is your spinal reticulothalamic pathway. As for the stimulus for your fast pain, usually mechanical or thermal. As for your slow pain, yung stimulus is usually chemical. And then the neurotransmitter involved in fast pain is usually glutamate, while for your slow pain, glutamate or substance B. As for your sensory fibers, yung fast pain ay yung fibers na involved would be A delta. And then yung slow pain, C fiber. Anong particular about C fibers? 'Di ba? C fibers, yung unmyelinated. Yun yung reason kaya slow yung transmission ng pain or slow pain. Yung difference pala ng fast pain sa slow pain, fast pain is that pain that you feel on the first second of injury. For example, na needle prick kayo. Yung needle prick na sensation, pricking sensation would be the fast pain, while yung slow pain would be yung parang burning pain around the area of the prick, kung saan yung prick. Oo. So yun yung definition ng fast pain and slow pain. So for your fast pain, yung termination of your first order neuron is at the lamina 1 or your lamina marginalis. While for slow pain, the termination of the first order neuron is at lamina 2 and 3 at the substantia gelatinosa and then at lamina 5. As for the second order neuron, so di ba sabi natin kanina, nag-determinate yung second order neuron at the DPL. So for fast pain, majority ng fibers ng majority ng second neuron would terminate directly at the thalamus, except for some fibers na nagte-terminate at the brainstem at the reticular areas. Versus your slow pain, which is widely terminated in the brainstem. Tapos 10 to 25% lang of the fibers would pass all the way through your thalamus. And this is the reason why yung localization din for fast pain would be more precise compared to your slow pain. So, yung localization for your slow pain is imprecise. So, halimbawa, na needle prick ka, alam na alam mo kung saan yan natusok. So, pero, yung swelling, the pain brought about by swelling, hindi na siya dun sa area mismo kung saan ka na needle prick. Okay. Yan. Okay. How about for pain perception? Ito yung sinasabi ko kanina. Yung third order neurons, again, would, upon reaching your thalamus, would project towards your somatosensory areas in the post-central gyrus and the superior wall of the sylvian fissure. And this areas are involved in the perception and discrete localization of pain. Kaya, 'di ba, majority of your fast pain fiber of your fast pain third neuro second order neuron would reach the thalamus as compared to your slow pain na nasa reticular areas lang. And that's the reason kung bakit mas localized yung pain sa fast pain. Pero, actually, if you completely remove your somatosensory area, halimbawa, tinanggal mo yung buong cortex, studies show na hindi niya nape-prevent yung pain perception per se. So yung conscious perception of pain is actually not the function of your cortex, but of the reticular formation, thalamus, and your lower brain centers. The cortex, on the other hand, um, serves a purpose in the interpretation of pain quality. Then tandaan nyo to, yung anterior cingulated gyrus, pain fibers could also project to the anterior cingulated gyrus and are likely to mediate suffering and the emotional components of pain. Okay, next question na. So, which is not involved in the inhibitory modulation of pain? Sige nga, A, B, C. A is norepinephrine. B is serotonin. C, calcitonin gene-related peptide. Sige nga, hula-hula lang to kasi medyo ito yung additional na dadagdag ko aside from the asynchronous. Okay, may answer kayo? Okay, some answered B, some answered C. Okay. So the answer is CGRP. So C, calcitonin gene-related peptide. Kasi yung norepinephrine mo ang serotonin mo is involved in the analgesia system of the brain. Okay. While your norepinephrine is inhibitory, causes direct inhibitory modulation of the pain pathway. So, review lang yung so meron tayong sariling anti-nociceptive pathway or analgesia system. So, it involves the periaqueductal gray, which receives information via the spinal mesencephalic tract and processes the nociceptive information and release it to the part of the medulla. So, sa part ng rostral ventral medulla, so RVM. So, yung next na involved part of the brain would be your raphe magnus nucleus at the lower pons and amygdala. And yung activation nito would activate the endogenous opiate system, leading to enkephalin production. Yung enkephalins natin, yan yung mga ating endogenous opioids. Kasi parang sarili nating morphine sa katawan natin. Ganun yung enkephalins. And then, it would send signals to the pain inhibitory complex located in the dorsal horn. Tapos yung pain inhibitory reflex na to would release serotonin. So, yung figure sa right would summarize yung ascending and descending tracts. So, ascending tract is your pain pathway. It's your spinothalamic tract. And then descending, yung pababa, would be your analgesia system or your descending inhibitory tract. So again, itong nasa green, the analgesia system would start at the periaqueductal gray and then would process information, the pain information, and send signal down to the rostral ventral medulla, RVM, which would send inhibitory signals again down to your spinal cord and would activate yung endogenous opioid system and the production of your serotonin. Tatandaan nyo, yung involved sa modulation na area would always be dorsal horn. Okay. Yung area sa spine na involved for modulation is dorsal horn. Okay. So, yung inhibitory transmitters for modulating pain. So, kung matatandaan niyo kanina, di ba algogen yung yung serotonin? So, serotonin can inhibit or promote pain. Tapos magkaibang pathway niya ginagawa. So, it promotes pain peripherally by increasing the sensitivity of your nociceptor, while it inhibits pain via the descending inhibitory pathway. Ito ay central action ng serotonin mo. This is versus your norepinephrine. Yung norepinephrine mo talagang inhibitory siya. Predominantly inhibitory to the pain pathway. Okay. So, punta na tayo sa exciting part. So, exciting part natin would be yung case-based pain assessment natin. So, sa mga na-under sa akin sa lab, lab con, so, ang tinuturo ko usually is old card. Pero for this session, ang gagamitin natin sa pain assessment na tool would be Socrates. So, Socrates. So, S for sight. So, it's important na kapag nag-assess ka ng pain, gamitin mo yung mga terms na comfortable yung patients with. For example, yung sight. How would you ask that? So, tatanong nyo, saan po ba masakit? Saan po pinakamasakit? Ituro nyo po. So, ask the patient to point where the pain is coming from. O is onset. Kailan po nagsimula yung sakit nyo? Oo. C, character. Ito, maraming description of pain eh. So, pwedeng pinipilipit, dinadaganan, tinutusok, parang may apoy or parang ganon, burning pain, yun yung tinatawag dun eh. Or parang may kuryente. Parang may kuryente po. And then radiation. Pag radiation, dito lang po ba sa dibdib, parang kumakalat yung sakit. Ganun siya tanungin. Then associations. Yung associations would be the additional symptoms that your patient feels aside from the pain. So, usual niyan would be nausea, vomiting, dizziness, fever. Okay. Loss of consciousness, ganun. Time course. Itong time course would be, you'd ask when the patient feels the pain the most. So, sometimes, ang question dito would be, tuwing kailan niyo po nararamdaman yung sakit? So, to assess yung time course, usually, persistent or intermittent. Tuloy-tuloy po ba ang sakit? Or nawawala-wala po? Yun yung intermittent. And then, minsan naman, may time frame talaga yung pain. For example, kailan po mas masakit? Sasabihin ng pasyente mo, sa gabi po. Or pagkatapos po kumain, mas masakit po. Ganun. As for the exacerbating or relieving symptoms, these are the things that makes the pain either go away or better or makes the pain worse. For example, kailan pong mas sumasakit yung ulo nyo? Or kailan po mas masakit yung tiyan nyo? Kapag humihiga po, usually mga positional changes or halimbawa, dietary changes, yun yung isasagot nila sa inyo for exacerbating or relieving factors. And yung severity, usually on a scale of 1 to 10. So marami tayong pain scoring available. Pero for this numerical rating scale yung gagamitin natin for this session. Okay? So lahat ng I have 4 cases for pain. So, lahat ng yun, gagamitan natin ng Socrates. Okay? So, yung first case natin, yung first patient pala natin would have a chief complaint of headache. So Jonah, a 25-year-old female, came in with a one-day history of left temporal headache, pulsating in character, with severity noted at 8/10. Prior to her headache, Jonah experienced light sensitivity. The pain seems to aggravate with loud noises and is associated with nausea and dizziness. Okay, so tandaan niyo yung case. So, try natin gawin yung sa Socrates method. So, side by side, yung sabi niya, left temporal yung site of pain. And then the onset is one-day history. Sabi natin, di ba, the definition of chronic pain is more than at least 6 months. So, yung one day is acute pain. She said that the character of her pain is pulsating. There's no note of radiation. Yung associations niya, kukunin nyo rin from the history. So, nausea, dizziness, and yung light sensitivity. Ang tawag dyan is photophobia or photosensitivity. Then, the time course would be persistent pain, and her pain exacerbates with loud sounds. Yung severity of pain is 8/10. Okay. So, may hula ba kayo kung ano to? Baka yung iba sa inyo meron ng ganito. Etong condition na to. Baka meron na kayo nito. Okay. Okay, correct. So, migraine. So, when yung headache, so headache is a type of pain that is referred to the surface of the head and usually comes from the deep structures of the head. So, headaches can result either from pain stimuli from inside your cranium or from pain arising outside the cranium. For example, pain coming from your nasal sinuses. So, yung mga may prone to sinusitis sa inyo, di ba? Nag-present with headache din. So, it must be noted na yung brain tissues nyo basically totally insensitive to pain siya, yung actual brain tissues. What is sensitive to pain in the cranial vault would be yung mga vascular structures. For example, your venous sinuses around the brain, the tentorium, and the dura, yung tinatawag na dura at the base of the brain. So actually, any damage dun sa meningeal vessels natin, particularly your middle meningeal artery, can cause headache. So basically, these are the areas of headache resulting from different causes. So stimulation of pain receptors in the central vault above your tentorium, including the upper surface of the tentorium itself, initiates pain impulses in the cerebral portion of your fifth nerve and therefore causes referred headache to the front half of the head. So as you can see here sa figure. So sa front half of your head, pag above your tentorial, supratentorial. Pag below the level of your tentorium naman, usually pain impulses would enter the central nervous system, mainly through the glossopharyngeal, vagal, and your cervical nerves, which also supplies the scalp areas from around the ear. So subtentorial pain usually causes what you call occipital. So dito sa occipital part of your head. So as I said kanina, yung nasal pains, nasal sinus pains and eye headaches would manifest dito sa area ng face and forehead around the areas of your sinuses. Okay. So, kailangan i-differentiate yung migraine from your tension head. So migraine usually lasts for 4 to 72 hours. So 3 days. Usually unilateral yung location nito. So makaka-relate ito yung mga may migraine. So with pulsating yung character of pain. Usually moderate or severe yung pain intensity and is aggravated by physical activity, accompanied by nausea or vomiting, tapos may sensitivity to light or sound. Actually, yung sensitivity of light and sound, or what you call photosensitivity, would already occur for some cases around 30 to 60 minutes before the actual attack. Ang tawag doon would be your migraine aura. Yung migraine aura, hindi lang siya photosensitivity. Minsan, nagkakaroon ng loss of vision sa peripheral parts or sa some parts of your field of vision. Minsan naman, nagkakaroon ka ng sensory hallucinations or yung parang glaring vision 30 to 60 minutes prior to your attack. So, hindi lahat ng migraine meron ganun na. May cases na without aura, meron din na with prodromal symptoms or aura. Okay? So, yung tension headache naman, ang quality of pain yan would be bilateral. Usually, ang description natin dyan is like a tightening band around your head. The intensity would be less compared to your migraine. And then it's usually not activated by routine physical activity, but you would also have sensitivity to lighter sound during actual attacks. Okay. So, ang fury with regards to your migraine is nagkakaroon ng reflex. Kasi any theory about migraine or migraine headache should also explain yung prodromes na involved sa migraine. So, yung theory about migraine would be a reflex vasospasm secondary to intense emotion or stress, which leads to ischemia. So, vasospasm would lead to ischemia of some parts of the brain. And thus, that explains the prodrome or the aura. And then, yung reflex vasospasm then would lead to exhaustion of your smooth muscles. So, dahil exhausted yung smooth muscles mo, the vessels would become flaccid. Kung flaccid yung vessels, it would be easily dilated and pulsating in nature. So, kaya pulsating yung characteristic ng pain in migraines. So, okay, care for a cup of coffee. So, ito yung question ko para sa inyo. Ito na actually na-touch on ito sa GI about caffeine eh. So, renal. What is the mechanism of action of caffeine that contributes to treatment of migraine? Sige. Ako personally, umiinom ako ng 2 cups of coffee kapag nagma-migraine attack ako. So ano kaya yung mechanism of action of caffeine that contributes to the treatment of your migraine? Okay. Okay. So anong receptor yon? Anong receptor yung binablock niya? O, tama si Paulo Fabres. Tama siya. So, ang binablock niya would be, actually tama rin yung iba kasi ang binablock niya would be your adenosine A2A receptor. So, na-discuss din natin to last time sa sa lab conference or sa laboratory, yung mechanism of action of your caffeine. Tapos, it leads to a decrease in cerebral blood flow through vasoconstriction. So, may vasoconstriction. Tapos, sinasabi nga natin na relax yung brain. Ang brain relaxation could be achieved if the vessels inside of it would be vasoconstricted. Oo. Okay. So, yun yung mechanism at which nakakatulong ang kape sa treatment of migraine. Next. Next case natin would be a case of a right lower quadrant pain. So Jake, 18-year-old male, came in with a 2-day history of right lower quadrant pain, characterized as dull, aching, with severity of 7/10. The pain was noted to start at the epigastric area, but then suddenly shifted to the right lower quadrant. So aside from pain, Jake also presented with fever, nausea, and vomiting. So side by side ulit ah. So yung site ng pain natin, na na-note ni Jake would be an epigastric pain that migrated to the right lower quadrant. The onset is acute, 2-day history. According to him, the characteristic of pain is dull and aching. The radiation of pain, so no noted radiation. Tapos associations would be fever, nausea, and vomiting. Time course is persistent. Relieving factors, non-noted, and severity is 7/10. So, referred pain. So, discuss natin muna yung referred pain. So, yung figure on the left would show the surface areas of referred pain from different visceral organs. So, kung hula natin kung anong diagnosis ng patient kanina, it would be appendicitis. No? So, for the appendix, pain is usually felt at the umbilical area or sometimes at the area of the epigastric. And then, for example, other referred pains. Kunyari, heart issues. Some people would present with epigastric pain of substernal pain. Some patients would present with left arm pain. As for your gallbladder or your for gallbladder pain, some patients would also present with scapular pain. Tapos yung proposed mechanism for referred pain would be that the branches of your, as seen on the figure on the right, is that the branches of your visceral pain fibers are shown to synapse in the spinal cord on the same second order neurons that receive pain signals from the skin. So when the visceral pain fibers are stimulated, pain signals from the viscera are conducted through at least some of the same neurons that conduct pain signals from the skin. So ang pakiramdam ng person is that yung sensations would originate dun sa part of the skin node. Okay. So, nag-migrate ba talaga yung pain niya sa appendicitis? So initially, pag sa acute appendicitis kasi, yung visceral and afferent nerve fiber mo at T8 to T10 are stimulated. Thus, and thus, the vague pain at the epigastric region. And then, as the appendix gets more inflamed, lalaki yung appendix, and it would irritate the peritoneum. So the parietal peritoneum will be irritated, yung fibers from which the na nag-innervate sa yung parietal peritoneum would be your L1. Saka nalalabas yung localized pain at the right lower quadrant. So nag-migrate pa? Basically hindi. Mas nauna lang na stimulate yung iyong visceral fibers at T8 to T10. Okay? Sorry. Kailangan nyo ba ng break? Or Gina tayo? Gina tayo? Okay. Kailangan nyo ba? Gina. Okay, very good. Okay, so case number 3. Okay, a patient came to you with chief complaint of inadequate pain control. Okay, so a 44-year-old man was recently diagnosed with adenocarcinoma of the pancreas. He has already been experiencing intermittent pain localized in the epigastric region for a year prior to his diagnosis. He describes his pain as knowing and is first with score of 8 over 10 during at night. So the patient also reports nausea and vomiting, and he has been taking tramadol 50 milligrams as needed every 8 hours for breakthrough pain, which just minimizes the pain a bit. So the patient came to you for pain management. So ganun ulit. So kunyari kayo yung GP niya. So site ng pain ni Menandro would be at the epigastric area. Onset, nakalagay dito, uh, he has already been feeling the pain for a year. So chronic. Ang cutoff natin would be 6 months. The characteristic would be knowing. Radiation of pain, non-noted, uh, supposedly localized in the epigastric area. Associations would be nausea and vomiting. Time course is persistent and usually presents at night. Relieving factors by taking tramadol. And uh, severity is 8 over 10. So basically yung pain niya is a chronic type of pain that can be either nociceptive or neuropathic. Third, this is actually cancer pain. So yung cancer pain natin, meron siyang elements. Yung elements of components of cancer pain would be sensory. Yung sensory component of cancer pain can be nociceptive or neuropathic. Pag sinabi nating nociceptive, can be somatic or visceral. So somatic pain usually superficial, sa skin, sa bones, usually localized, sharp pain. Tapos yung description of pain would be dull and aching. As compared to your visceral pain. Yung visceral pain naman, usually yung irereklamo sa'yo ng patient would be a diffuse kind of pain. And then, it's referred to a surface. For example, if meron siyang pancreatic cancer, usually ang referred surface then would be at the back. And then meron for neuropathic pain naman, usually it's due to pathologic damage to your neurons. Bakit magkakaroon ng pathologic damage to your neurons for cancer? First, dahil sa invasion. So, yung cancer, yung tumor, nag-encroach na siya to your normal nerves. And then, pwede rin compression. Naiipit niya yung nerves. Or, ano pang thing with cancer pain na dapat tinanong kay Menandro if nag-undergo siya ng treatment. Because treatment, chemotherapy can also damage your nerves. So, pwede rin magkaroon ng pain ng pasyente because of therapy. So, either chemo or radiotherapy or surgical intervention. All can cause pain, neuropathic pain, secondary to cancer. So, ang description ng, pag sinabing neuropathic pain, ang description ng patient would be burning, lancinating, numb, masakit na manhid, pero masakit dok Ganon. And then, tatandaan natin, for chronic pain, very important yung psychological component, especially for chronic pain. And yung psych impact nito usually leads to fear, anxiety, depression, uncontrolled anger. And 25% of patients with cancers with cancer pain would already meet the criteria for MDD, for depression. So, what causes pain in the cancer? So, first, presence and progression of tumor. Yun, pwede niyang pwedeng meron ng bone involvement or na-obstruction na yung viscous, or if the nerve has already been compressed. And cancer tumors can also have an indirect effect. Can lead to metabolic imbalance, infections, venous or lymphatic obstruction. And then, as I said earlier, consequence of cancer treatment. Secondary to chemotherapy, radiotherapy, surgical therapy. Ako, very important na when you're talking to a patient with cancer, you consider na uh, matagal na nilang uh, hawak yung pain. So, eto lagi ko sinasabi na pwede ka naman focus sa physiology, medical treatment, management, but don't forget to be humane. So, always ask for questions na leading para ma-assess mo yung psychological status of your patients. So, always be kind din sa lahat naman ng mga pasyente natin. Okay. So may tinatawag na WHO analgesic ladder, and this has been used to treat cancer pain. So yung step 1 would be the use of non-opioid plus minus an adjuvant. Yung non-opioid would include your NSAIDs or your non-steroidal na anti-inflammatory drugs or your acetaminophen. Yung acetaminophen is kilala nyo siya as paracetamol. And then if it persists or if the pain increases, isa-start mo na siya with a weak opioid. And then a non-opioid and an adjuvant. Yung adjuvant natin would be your steroids, your antidepressants, your anticonvulsants, including gabapentin, pregabalin. And then yung step 3 natin would be strong opioids na. And then ang goal would be freedom from cancer pain. Merong pinapropose, pang-apat na step sa ladder. So yung fourth step would already be the use of interventional treatment. Anong example ng interventional treatment natin? Nerve blocks, spinal blocks, yung mga opioid infusion system na patient yung nagpo-control. So, pinipindot nila, mabibigyan siya ng opioids. And then, spinal stimulators. Okay. So, review lang. Emphasize ko lang yung mechanism of action ng opioids. Very special yung opioids kasi meron niyang special na receptors eh. Check nyo na lang dun sa asynchronous ko, yung mu, kappa, delta receptors for opioids. So, yung mechanism of action ng opioids would be centrally or peripherally. So, sa central, basically, it inhibits the calcium influx presynaptically. And then, postsynaptically naman, ang ginagawa niya is it enhances potassium efflux naman. And nangingialam din siya dun sa GABAergic inhibition of the GABAergic transmission in the brainstem. Peripherally, it works at the level of your primary afferent neuron, and it works to inhibit the release of your pro-nociceptive and pro-inflammatory substances. Okay, meron akong favorite pain reliever. Ang favorite pain reliever ko is paracetamol. So, ano lang, extra info, kwento-kwento. Ang kwento ko rito is nung residency ko lang nalaman yung mechanism of action ng paracetamol. So, bakit ko siya favorite drug? Kasi it's a simple drug, but it has a complex mechanism. So, yung acetaminophen mo, actually, it works at both ends of your nociceptive pathway. Both dun sa transduction, sa part ng transduction and transmission, and dun sa inhibitory modulating path or yung descending pathway. So first, it leads centrally by inhibiting the pain pathway through augmenting your descending serotonergic and endocannabinoid pathway. And then peripherally, it works by weak inhibition of your cyclooxygenase, COX-1, 2, and 3. So for me, one of the wonder drugs ever created yung paracetamol for pain. Okay. Halimbawa, the family of your patient is worried about addiction. Ayaw nila ma-start yung patient, si Menandro, ng opioids. So first, you should know the different terms uh, with regards to opioid use. So yung addiction would be persistent pattern of dysfunctional use of opioids and typical drug-seeking behavior. Your tolerance would is the need to gradually escalate your dose to achieve the same pain control. So basically, pag nagiging tolerant ka, nag-a-adapt, yung kumbaga, mas mataas na yung dose na kailangan mo to treat the same level of uh, pain from before. And then yung physical dependence naman is the development of withdrawal. So magkakaroon na ng withdrawals after the abrupt discontinuation of medication. So kunyari, yung patient nyo is, the family of your patient is worried about addiction, uh, like, yung studies would show that patients with chronic pain, hindi naman siya are at higher risk for addiction compared to the general population. Dito na papasok yung patient education and then yung clear na discussion of the pain treatment with your with the family of your patient and your patients. So, lagi niyo tatandaan, patients with cancer pain should never be undertreated just because of your fear for addiction. Sabi nga namin sa amin, pain is an emergency and pain is subjective. Pag sinabi na pasyente na masakit, consider mo na masakit yung nararamdaman niya. Fourth and last case with regards to pain would be with the chief complaint of pain on amputated leg. So Conrado, a 67-year-old male, underwent below-the-knee amputation of his leg 8 months ago. And then he came in with persistent pain radiating from the BKA, yung stump kung saan na-amputate yung leg, to the area of his now amputated leg. So yung pain from the stump would still radiate to the area na supposedly wala na dun yung leg. Described as nangunguriente with severity of 3 to 4 lang naman over 10. The patient, but because the pain is persistent, the patient is noted with difficulty sleeping secondary to the nagging pain. So, side by side, again, yung site niya would be the BKA stump. Onset is chronic since it started 8 months ago. The character of pain would be nangunguriente. So, pag nagte-take down kayo ng characteristic of pain, take down nyo kung paano din actually dinedescribe ng pasyente nyo yung sakit nyo. So, kung sinabi niyang nangunguriente, yun yung isusulat nyo dun sa examination nyo, dun sa history nyo. Sorry. And then, yung associations would be yung insomnia. Time course is persistent. Every day siya merong difficulty of sleeping because of the nagging pain. The exacerbating factors, non-noted, and then severity of 3 over 10. So, ito yung tinatawag na phantom pain. So, pain, imaginary pain, kumbaga, parang ganun. So, phantom limb pain is the perception of pain or discomfort in a limb that is no longer there. So, yung usual classification ng phantom pain mo is neuropathic and usually nagiging chronic condition to, itong phantom pain. And then, sa studies, 95% of post-amputee patients report experiencing some amputation-related pain. with 79.9 reporting phantom pain. So yung phantom pain is different than residual limb pain. Yung residual limb pain, usually yung pain na talagang nandun lang sa stump. But pag sinabi mong phantom pain, dun siya sa area kung saan tinanggal na yung leg or tinanggal na yung appendage, kumbaga. And hindi lang siya sa leg ha. So other parts na pwedeng magkaroon ng phantom pain would be, for example, breast after MRM or after mastectomy, rectum, the penis, testicles, eye. So pwede may eye pain yung mga patients na post removal of eye. And then tongue and teeth. So nabunutan na pero masakit pa rin yung ngipin. Kumbaga. Okay. So the phantom limb can bring about both painful and non-painful sensations. So sa painful sensations, most are indicative of neuropathic pain. Yung residual pain, sabi ko kanina, is different from phantom limb pain. So yung residual limb pain, usually doon lang siya sa stump. Yung phantom limb mo naman would be perceived to originate at the phantom hand, okay, or phantom or appendage. And then around 1/4 of your patients na post amputee would feel the phantom limb pain at least once a day. So ang dami na, no? 1/4 at least once a day. Well, half of the patients would present with at least a pain score of 4. Tapos yung description of pain would be burning sharp, cramping, electric shooting, stabbing, or throbbing. So, yung mga supposedly causes of your phantom limb pain is summarized in this diagram. Actually, wala to dun sa special topic lang naman to, pero i-discuss ko na rin. So, yung peripheral nerve changes, usually secondary to trauma dun sa nerves and surrounding tissues, secondary to your surgery. Sabi ko nga, so yung any damage secondary to surgery or any treatment can lead to a neuropathic kind of pain. So, yung damage na to would disrupt the normal afferent and efferent signals involved with the missing limb, and pwede rin chronically pwedeng magkaroon ng neuroma formation at the stump and making the nerves hyperexcitable due to yung changes sa sodium channels and yung spontaneous discharges from the neuromas. Okay? Yung with regards naman sa spinal cord changes, basically central sensitization yung nangyayari. So it is usually secondary to an increase in neural activity, neuronal receptive field expansion, and yung hypersensitivity of your nerves. Nagkakaroon din ng increase in NMDA receptor activity mediated by substance P and tachinins and neurokinins. Okay. And then for your brain, isa sa mga proposed mechanism ng pain sa phantom limb would be your cortical reorganization. So, ang nangyayari sa cortical reorganization is that the areas of the cortex that represent the amputated area are taken over by the neighboring regions in both the primary somatosensory and motor complex. Ito yung reason kung bakit yung nociceptive stimulation of the nerves in the residual limb and surrounding area can cause pain and sensation in the missing limb. Okay. So, dahil sa cortical reorganization, kaya iniisip, meron ako napanood yung illusory technique. So, parang mirror technique to improve yung phantom limb pain. So, pwede nyo na lang siya gawing additional reading. So, pag sinabi nating differentiation pain, it's pain due to the loss of sensory input into the central nervous system. Tapos, aside from this, meron ding psychogenic factor secondary to yung trauma of DKA, of chronic pain. Okay, special topic. Acupuncture analgesia. So, acupuncture involves the insertion of very thin needles. Nakakita na ba kayo ng acupuncture needle? Sobrang nipis niya. At strategic points in your body, on your body. So, acupuncture is most commonly used to treat pain. Pero marami rin siyang ibang uses. For example, for overall wellness, kasama na dun yung stress management. Possible mechanisms of acupuncture analgesia would be, actually diniscuss ko rin to sa asynchronous, review nyo na lang, is the gate control theory. So the stimulation of A beta fibers occurs, and then by ano kasi to so by pressure or by stimulation of your beta fibers, ang nangyayari is directly na-inhibit yung spinal transmission of your smaller fibers. Yung smaller fibers mo would be your A delta and C fibers. Itong gate control theory na yun, ito rin yung reason kung bakit nawawala yung pain dahil sa haplos ng pagmamahal or sa masahe. So kasama rin sa gate control theory yan. And then, yung acupuncture analgesia would also show that it was also shown to stimulate the production of your endogenous opioids. So, your happy hormones, ano yun, your endorphin and your enkephalin, by stimulating the descending inhibitory pathway. So, the endogenous analgesia system of the body. Ito, mga studies. So, sa human studies, sa analysis of the CSF fluid post-acupuncture, it was shown to have elevated levels of your serotonin, endorphin, and enkephalin, all of which are involved in the descending inhibitory modulation system of the body, di ba? And then, sa MRI, low and high frequency electrical acupuncture would also induce enkephalins and dynorphins. And then, malalaman mo na enkephalin and dynorphin na yun because the analgesia can actually be reversed by giving naloxone, which is an opioid antagonist. And then, yung acupuncture manipulation sa Hego point. Yung Hego point yun nandito sa picture. At ang tawag dyan ay LI, large intestine 4, is seen to modulate activity of the limbic system and subcortical structures. So, merong mga real acupuncturists and sham acupuncturists. So, na-differentiate din yun. So, in a study, there is higher activation with real acupuncture over the hypothalamus and the primary sensory cortex. Tapos, na-deactivate din yung sa anterior cingulated cortex. Oy, na-interact, ay na-encounter na natin tong anterior cingulated cortex, di ba? It's involved in the emotional and suffering component of pain, perception of pain, di ba? So, acupuncture as a treatment modality for pain, so ang consensus is that acupuncture is an effective therapeutic intervention with promising intervention to dental pain, headache, menstrual cramps, tennis elbow, fibromyalgia, osteoarthritis, and back pain. So, pwede siyang gawing adjunct treatment at actually, pwede rin siyang acceptable alternative to an intervention. And then aside from pain, other uses of acupuncture would include yung treatment of post-op nausea and vomiting. So, iba naman yung point dyan, pericardium 6. And then decreasing anxiety, inducing of your sedation. Yung point naman dito is in between your eyebrows, yung yintang. Okay, So, ituloy na natin. Short lang to, ha? Para matapos na tayo. And then, basics on temperature. So, true or false? Again, question and answer ulit tayo. There are more heat receptors than cold receptors in the body. Okay. True or false? Sige nga. Yeah. Okay. Okay. So, tama kayo. False. So, there are 3 to 10 times as many cold spots as your warm spots. So, mas maraming cold receptors than your heat receptors. So, ito yung different gradations of thermal sensations that are determined by relative degrees of stimulations of the different types of endings. So, halimbawa, at temperatures less than 5 degrees, only the cold pain. So, may cold pain fibers, heat pain fibers, cold receptors, and warmth receptors. Usually, the cold pain fibers are stimulated below the temperature of 15 degrees centigrade, and your heat pain receptors are activated above 45 degrees Celsius. Ito yung sinasabi ng extremes of temperature. And then, as the temperature rises to around 10 degrees or 15 degrees, the cold pain would begin to cease. So, bumababa siya. And would, sorry. And the cold receptors would begin to be stimulated. Yung peak ng stimulation of your cold receptor would be at 24 degrees Celsius and would slightly fade out dito sa 40 degrees. Your warmth receptors would begin to stimulate around 30 degrees, would peak around 44, 44 degrees, and would decline until 49 degrees. So as I said earlier, yung heat pain receptors nyo would be stimulated at 45. Yung itong heat pain saka cold pain, basically, they are just nociceptors. Yung pain receptors. Tapos, ibang klaseng receptor naman yung involved with your cold, yung in between 15 and your cold receptors and your warm receptors in between yung 15 degrees saka 45 degrees na extremes of temperatures. Yung involved sa cold receptors would usually be A delta fibers, while yung warm receptors mo are usually free nerve endings. Tapos yung involved naman ng fibers usually are the C fibers. Okay. True or false? When a large skin area is stimulated all at once, the thermal signals from the entire area are cumulative. Okay. Okay, tama. So, tama, true. Oh, for example, magdadampi ako sa skin mo ng small piece na malamig or hot na needle, for example. Less yung sensation nun compared if ang idadampi ko sa'yo ay mas malaking hot na substance or hot na bagay, kumbaga. So, rapid changes in temperature, ang tawag dito would be the effect of summation. Ito, next slide. Effect of summation. Basically, yun nga, when a large skin area is stimulated all at once, yung thermal signals from the entire area ay cumulative. So rapid changes in temperature for as little as 0.01 degrees can be detected if this change affects the entire surface of the body simultaneously. Tapos differentiate natin siya sa adaptation. So yung adaptation mo would be, for example, there is an abrupt fall in temperature. So initially, your cold receptor or your heat receptor would be strongly stimulated. And then as you adapt, the stimulation fades during the next few seconds or minutes. So ito yung reason, kunyari, pagka may hot tub, pagkapasok mo sa tub, initially sobrang painful and then kaya mo na siyang i-tolerate. Same as, for example, you came from a hot day, then pumasok ka sa air condition room. The reason why pagpasok mo sa aircon room, parang sobrang lamig and then eventually, normal na lang yung pakiramdam or normal cold. So, isa sa mini-maintain ng katawan natin to maintain the internal milieu or the homeostasis would be its temperature. So involved in thermoregulation would be a balance between heat production and heat loss. Sa heat production, ang involved dyan would be your metabolism. So your basal metabolic rate, the metabolism associated with muscular activity, tapos yung hormonal effects on metabolism, particularly your thyroid hormone. And then, you should balance it with your heat loss. Yung mga usual causes of heat loss would be your radiation, conduction, evaporation, convection, and then your blood flow and insulation. So, what are the factors determining rates of heat production? So, kasama nga dyan yung BMR, your basal metabolic rate, muscle activities, thyroxine effect, sympathetic stimulation, cellular chemical activities, and the thermogenic effects of food, di ba? Especially, for example, carbohydrates. And then, as for heat loss, yung 60% of heat loss, so majority ng heat loss would be from radiation. Yung radiation is the loss of heat secondary to infrared heat rays. Yung infrared heat rays would be at 10 to 20 times the wavelength of your visible eye. And then next na cause of your heat loss would be your conduction. So yung conduction to air would consist of 15% of heat loss secondary to conduction, and then yung conduction to actual objects would be 3%. So conduction is loss of heat from the body to a solid object. And then next would be evaporation. So 22% of loss of heat can be secondary to evaporation. So evaporation is the loss of heat from bodies through water vapor to the surrounding atmosphere. Yung convection naman, ang involved dyan would be changes in the external environment. For example, air currents, wind, water, so convection. So these are a summary of the thermoregulatory responses activated by exposure to cold. So for example, shivering. For exposure to cold, mayroon tayong shivering, increase in voluntary activity, increase in TSH, increase in catecholamines, vasoconstriction, piloerection, or tumataas yung balahibo, yun yun. And then curling up. And then the thermoregulatory response involved in activation, in the activation by exposure to heat would be vasodilation, sweating, increase in respiration, anorexia, apathy, and decrease in TSH secretion. So, ito magandang diagram to. Kailangan maintindihan niyo siya. So, dito sa red part, dito sa right upper part, so, for example, you have an increased body temperature. So, yung temperature-sensitive receptors in your skin and your hypothalamus would react to the heat. So, una, nagkakaroon ng voluntary responses. Ang ginagawa mo, you reduce your activity, you expose yourself to cold environment, you loosen your clothing, you drink cooling drinks. And then, the thermostat in the hypothalamus, ito sa left side left upper part naman of the diagram, is when the hypothalamus would activate the cooling mechanism. Ano ba yung mga cooling mechanism na yon? For example, if the activation of your parasympathetic system, so leading to sweating. So through sweating, you increase heat loss. So yun yung goal mo eh, di ba? If exposed to heat, kailangan mailabas mo yung heat. And mapababa mo yung heat production. So, and also, yung isa pang mechanism would be sympathetic nervous system inhibition. So, ang nangyayari, nagkakaroon ng vasodilation. With vasodilation, nag-increase din yung heat loss. And with a decreased basal metabolic rate, mas mababa naman yung heat gain. Okay? So, yan yung responses to an increase in temperature. Tapos, baba naman tayo dito tayo sa blue part. So, yung nasa blue box, so there's a decreased body temperature. So, syempre, ang goal natin dito is to generate heat or to reduce heat loss, di ba? Kasi bumaba yung body temperature mo. So, temperature-sensitive receptors in the skin and the hypothalamus would lead to voluntary responses. Basically, you eat, you increase your muscle activity, you wear warm clothing, and you seek for heat source. And then, in the level of that hypothalamus, it activates your warming mechanisms. Ano yung mga warming mechanisms ng katawan? First, it increases the thyroid hormone. So, increasing the thyroid hormone would increase the basal metabolic rate. So, increasing the basal metabolic rate would generate heat. So, heat production. And then the sympathetic nervous system would be activated, leading to, again, increase in basal metabolic rate, vasoconstriction. Vasoconstriction would actually reduce your heat loss. So, pag malamig, di ba, na parang malamig din yung extremities natin. That's secondary to vasoconstriction. Yung ginagawa ng katawan mo to reduce heat loss. And then erection, tumataas yung mga balahibo. Ang ginagawa naman nun, is that it traps air at the surface of your skin and acts as an insulator. And finally, shivering. Yung shivering mo, it generates heat. Okay, last na. One case lang on temperature and regulation. And then done na tayo. So, a hot day. So, Max, a 25-year-old male student, joined a 3-kilometer walk for a cause event. So, midway to the finish line, he suddenly experienced uneasiness and faintedness. When he was on the way to the emergency team, he suddenly started vomiting before going into a generalized seizure. He was assessed by EMTs and his temperature taken by forehead infrared thermometer was noted at 45 degrees. So, ano to? This is, may hula ba kayo? Anong condition to? Ano, may question, may message si Maria, sabi niya, how come there are more cold receptors than warmth receptors? So, technically, di ba, parang the body tends to keep, kumbaga, your body tends to keep your body warm. Oo. So, yung cold, yung hypothermia is, yun yung mas triggering for the body, hypothermia. Kasi kinkeep niya yung temperature mo at a certain range, 36 to 38 degrees. Okay. And maybe that's the reason why mas marami tayong we are made, the universe made us, or God made us na mas marami tayong cold receptors kesa sa warm receptors because mas kailangan ng katawan natin maging warm. So, parang mas comfortable yung body sa mas inclined tayo on being warm than being cold, kumbaga. Okay? Naintindihan yun. And then, tama, heat stroke. Okay. So, important, no? Kapag sasali tayo sa mga walkathon, to watch out for heat stroke. Wait. Okay, so heat stroke is a life-threatening illness characterized by an elevated core body temperature more than 40 degrees in Celsius and dysfunction of your central nervous system, which can result in altered mental status, delirium, convulsions, or coma. And then may triad of ang diagnosis of your heat stroke is largely clinical. Madali mo siyang ma-diagnose. Meron siyang triad, hyperthermia, neurologic abnormality, and yung classic form would be exposure to heat or physical exertion. Kunyari, nag-gym siya ng 4 hours or 5 hours, di ba? Exertional heat stress naman yung tawag doon. So, ito yung listahan ng consequences of deviations of your body temperature. Yung normal range of temperature would be at 36 to 38. Pag 38 to 40, you're said to have hyperthermia na or fever. Pero minsan, pag nasobrahan ng exercise, di ba, tumataas din yung temperature, lalapag din ng 38 degrees. And above 40, meron ng mataas na chance na magkaroon ng heat stroke. And yung heat stroke, hindi siya basta-basta. Meron siyang neurologic component and possible na mag-lead into organ damage. So, organ failures. At 34 to 36 naman sa kabilang range, there would be mild hypothermia. Tapos kapag yung temperature mo naman bumaba pa to 30 to 34, meron ka ng loss of consciousness. And below 20, at the level of 27 to 29 degrees Celsius, meron ng fibrillation or cardiac fibrillation. So, pwede na magkaroon ng death secondary to VF. Okay, so sinasabi na yung heat stroke involves a transition from a compensable thermoregulatory state to a non-compensable condition. So basically, yung compensable thermoregulatory state would be exercise of heat or heat stress leading to an increase in metabolic rate. And then due to the increase in body temperature, you would sweat. Tapos, tataas yung cardiac output leading to decrease in visceral blood flow and increase in skin blood flow. Kailan yung point na papunta ka na sa non-compensable thermoregulatory state? Kapag nagkaroon ka na ng decrease in central venous pressure. So, increase in central venous pressure would increase your core body temperature. And yung increase in core body temperature would lead to effects such as cell anoxia, gastrointestinal permeability, cardiovascular collapse, and inflammatory reaction. So, further increase in core body temperature would eventually lead to heat stroke. Isa pa would be SIRS can result, or SIRS is systemic inflammatory response system. And then SIRS can actually lead to your multiple organ failures. For example, liver dysfunction, acute renal failure, DIC, or coagulopathy, and then muscle breakdown and cardiac dysfunction, all of which would result to the classic signs of heat stroke. Ayan. Okay, yun lang. And Sana may natutunan kayo sa lecture ko. Kung may questions kayo, pwede niyong magpo-post ako maggagawa ko ng dito ng discussion board. Ngayon ba may questions pa kayo? Or time frame of ito yung ang question niya yung time frame ng chronic pain. Kasi may ibang tawag dito? May ibang definition na sabi is longer than 3 months. So, babalikan ko kayo, pero sa readings ko, it's always usually 6 months yung marker for chronic pain. Pero babalikan ko kayo sa discussion board. Can epinephrine also be considered as pain inhibition hormone? Yung from my readings, yung mga inhibitory neurotransmitters and inotropes na involved sa pain inhibition would be your serotonin and your norepinephrine, not hindi yung epinephrine, and enkephalins or endorphins, so opioids. Yun lang yung considered na part of your pain inhibition modulation pathway. Pwedeng makahingi. Yes, bibigay ko sa inyo yung copy nitong. Hindi ko talaga hin-highlight yung kasi dapat sumagot kayo sa hindi ko talaga hin-highlight yung mga questions, ay yung mga answers. Para kung hindi kayo nakinig sa lecture, hindi nyo masasagot yung questions, di ba? So, kailangan nyo hanapin yung answers. Okay. You mentioned that coffee is good for migraines. Is there a situation where coffee is not good to alleviate a headache? Okay. So, isipin natin. Yung coffee kasi, yung isa niya pang effect is tachycardia. So, for headaches, secondary to, for example, a cardiac condition na nagkakaroon ng parang may problem with, kunyari, oxygen consumption leading to headaches. Kasi, kunyari, mababa yung oxygen delivery sa brain. Pwede rin yung mag-cause ng headache. And then, usually, yung causes nun would be cardiac. So, for patients with my cardiac conditions or may mga palpitations, siguro hindi kayo dapat mag-coffee. Ayan. Pero kasama sa treatment plan for migraines, specifically migraines ang coffee. Tapos, wait lang. Ang question, is it required to read Guyton? Actually, yung nasa Guyton, yun din yung depende kung anong klaseng learner ka. Ako, sasuggest ko, ako talaga nagbabasa ako nung med school, nagbabasa talaga ako ng book para mas madali kong maintindihan. So, ang suggestion ko pa rin is read Guyton. Pa rin. Oo. It was mentioned po sa async lecture that repeated exposure to pain is a factor that decrease pain tolerance. Is that a different case po for people who train to increase their pain tolerance, such as those who engage in combat sports? Repeated exposure to pain is a factor to decrease pain tolerance. Kasi ito merong for example if you inflict your pain to yourself, hindi ba less painful siya kesa pag ang nag-inflict sa atin ay or ibang bagay? Halimbawa, a headache minsan is mas masakit kesa kapag like tinusok mo ng ballpen yung skin mo. Kasi may kinalaman yan sa yung conscious perception of pain or yung parang ang involved dito would be your more of your cortex. Kasi alam mo na nag-i-inflict ka sa sarili mo ng pain eh. So, 'di ba? Na-answer ko ba yung question? So, ito kasi yung sinabi mo for people who train to increase their pain tolerance. Merong kasamang kumbaga mind control, mind manipulation dun sa pain pathway. Good morning. Yung main reference ko would be Guyton. Oo. Would be Guyton. Question po, paano po malalaman yung kung paano po kung psychosomatic and actual physical pain? Dito pumapasok kung gaano ka kagaling mag-pain assessment. So, yun, anesthesiologist ako. Sabi nila kami yung pinaka-short pag mag-handle ng patients. Pero actually, kung may isang part of anesthesiology na mag-involve ng sobrang habang interview, it would be pain assessment. So, yung psychosomatic or actual pain, kung paano siya ma-differentiate through examination. Kasi alam mo naman yung kunyari, actual description ng acute somatic or acute neuropathic or chronic neuropathic or chronic nociceptive pain, di ba? So, kung hindi pasok doon, or kapag nag-iisip ka na possible na may psychologic uh, problem yung patients. So, ako personally, hindi ko siya tinitreat kagad na psychosomatic. Why? Para sa akin, siya, medyo waste basket. Kung wala na akong makita sa physical exam, wala na akong ma-assess by giving medication, saka ko lang siya sabihin na psychosomatic pain lang siya. Always remember na kapag sinabi ng pasyente na I'm in pain, kailangan mong bigyan ng consideration na baka may actual physical na cause yung sakit na nararamdaman ng patient. So, yun yung medyo minsan na neglect natin eh. Okay. Doc, regarding pain threshold and pain tolerance for every individual, does it have to do with how the body perceives the stimulation differently? Ito, babalikan kita with regards to pain threshold and pain tolerance. For example lang, ang example ko dito would be neonates. Yung, di ba sabi natin na more for yung pain, talagang visible na siya sa pediatric patients more than 3 months of age. Tapos, so, halimbawa, yung mga neonates natin would have high threshold for pain and high pain tolerance. Compared to, for example, yung fragility, kunyari fragile yung elderly, they would feel, they would have a lower pain tolerance compared to normal individuals or, for example, neonates. So, depende rin sa, kunyari, sa age, sa culture, kung saan, sa culture, sa environment, kung saan lumaki yung person. So, lahat tayo, yung pain tolerance and pain threshold, pwede mag-iba. Depende rin dun sa beliefs, cultures, environmental exposures, ganun. Okay, next. Good morning, Doc. What is the best way to increase pain tolerance? Bakit? Bakit mo to gusto? Bakit kaya na gusto mo Actually, yun nga yung sinasabi ko kanina, at a certain age, yung pain tolerance natin is mataas na enough. And then, kapag medyo fragile na tayo, as we get old, nagde-decrease ulit yung pain tolerance. So, what is the best way to increase pain tolerance? Kanina actually may nagtanong na yan. Merong mga gumagawa ng parang may exercises sila, strengthening exercises, or that parang nagbibigay ng repeated conscious na stimulation dun sa ah, sorry, yung conscious stimulation or constant stimulation just to increase yung pain tolerance. So, yun. Para to dun sa mga persons na involved kunyari dun sa mga may physical or combat na ano, involved in combat na exercises or sports, di ba? Oo. May questions pa ba? Oo. Yung ano, ang babalikan ko is yung ulit. Okay. Okay. So, tama. Thank you dun sa nagsabi. Yung updated definition ng IASP for chronic pain is pain um, more than, at least persisting for 3 months. Thank you for updating. So, gusto ko yun na ina-update yung information natin. Okay. Thank you, Cherish. Okay. Meron pa bang ibang question? Salamat sa participation nyo ha. I love it. Kung wala ng question, pwede nyo naman ako i-email or mag-open ako ng discussion board para mas makapag-usap pa tayo. Pwedeng katulad ng ginawa ni Cherish na pwede kayong mag-hain sa akin ng mga studies o kaya ng mga nabasa yung mga bagong journals to update information. Sabi ko nga, open tayo to evidence-based medicine. And, ay, ito pa. Yes, ito yung sinasabi natin is actually ito yung hanap ko term kanina. Kasi ang question niya would be, would physiological conditioning help to significantly increase pain? Ito yung hinahanap ko na term kanina, yung psychological conditioning. So, iba kasi kapag ini-inflict sa'yo yung pain, kaysa ikaw yung continuously na nag-i-inflict ng pain sa sarili mo. So, by continuously inflicting pain, nagko-condition yung mind mo to accept that level of pain. Okay? As compared na, kunyari, pinalo ka ng pinalo ng ibang tao, habang pinapalo ka continuously, the pain would mas madidecrease yung tolerance mo dun sa inflicted pain. Kasi wala ka pang nagagawang psychological conditioning. Okay. May questions pa ba? Before we go? Salamat sa mga tanong. Pwede pa kayong magtanong? Okay. Ayun lang. Okay na, mukhang walang questions, no? Magpo-post na lang ako ng discussion board. Okay. Ay, meron pa. Oo. Ano po ang pwedeng management for central sensitization? Yung central sensitization, clarify natin. Yan yung sa secondary hyperalgesia, yung wind-up phenomena na tinatawag. Tapos, yan din yung sa receptor field widening. So, yung mga management na pwede dyan, pwede mong i-make use yung iba't ibang pathways. For example, pwede ka magbigay ng NMDA antagonist or anything that can counteract yung increase ng glutamatergic na nociceptors. Or pwede ka rin mag-start ng ibang medications that would target naman yung modulation. So, ano yung ta-targeted mo sa modulation pathway? Basically, dun sa descending pathway, ang pwede mo i-target would be, for example, uh, yung mga central, pwede ka magbigay ng opioids. Although yung opioids pero sa ibang reading na yun, can also lead to opioid-induced hyperalgesia. Pero sa ibang reading na yun, possibly sa pag second year na kayo, ma-learn nyo yung about yung opioid-induced hyperalgesia. Pero basically, pwede ka magbigay ng opioids, tapos yung targets mo would be yung central mechanism niya. Mm-hmm. And then, ano pa? Paracetamol. Paracetamol naman ang target niya is again yung modulation pathway, yung descending modulation pathway. And aside from yung descending modulation pathway, meron ka ring tawag dito, peripheral action at the level of your COX. So, COX-3. More of COX-3 yun sa paracetamol. Okay? Pero mahirap i-treat yung central, pag nagkaroon na ng central sensitization. Usually, kailangan mo mag-balance analgesia na talaga. So, magko-combine-combine ka ng medications. Just so, kasi lahat ng medications natin for pain would also have side effects. And kapag hindi mo binalance yung, kunyari, tinaasan mo ng sobra yung opioids, hindi ka nagdagdag ng ibang medications, pwedeng hindi balance yung analgesia mo, yung side effects sa patient would be mataas. Halimbawa, yung mga side effects ng opioids mo would be sedation, vomiting, nausea, pruritus, constipation, lahat ng yon. So, and then meron din siyang cardiac manifestation. So lahat ng yon pag hindi mo binalance at nagbigay ka lang ng high dose ng opioids, pwedeng mas mataas yung side effects. The reason why binabalance mo yung analgesia, nagdadagdag ka ng minimix mo. Yung opioids, yung NSAIDs, yung non-steroidal anti-inflammatory drugs, yung paracetamol. Ang reason is para minimize yung side effects ng bawat gamot na ipapasok mo dun sa treatment. Okay. Okay. Hi, Doc. Ito, fast pain conduct at 12 to 30 meters per second, while slow pain conduct at 0.5 to 2 Hindi. Kasi at 0.5 to 2 meters per second. Diba? 12 to 30, tama naman. Kasi yung fast pain mo, mas mabilis siya. 12 to 30 meters per second siya eh. As compared to your slow pain fibers na nagko-conduct lang at 0.5. Kumbaga, every second, ang minumove niya lang is 2 meters. As compared to your fast pain na 12 to 30, yung 12 to 30 meters per second yung minumove. Yes. Yun lang. May questions pa ba kayo? So, mahirap na i-treat yung pain eh. Kasi especially kapag chronic pain na. Pero at your level, ang pinaka-importante is yung emphasis on assessment. Dapat alam mo muna yung klase ng pain na meron yung patient. And then, yung recognition na hindi lang all na posible na hindi lang all physiologic yung problema or all objective or all trauma or injury, na posible na yung pain ay meron ding psychologic or psychogenic component. So, laging yun nasa back of your mind, pero hindi mo rin siya automatically na ilalagay sa waste basket na yon. Kailangan mo muna i-rule out lahat ng possible causes of your pain. Not related po sa lecture, but just wanted to ask kung ma-address yung question boards with regards to quiz B, quiz 8. Doc Jacinto, Doc, may question dito. Yung question is not related sa lecture but just wanted to ask kung ma-address yung discussion board questions regarding quiz 8. Doc RJ. Sige. Ay, yes,
Sorry,
diba?
regarding saan?
Just wanted to ask daw po kung ma-address yung discussion board questions regarding quiz 8.
Quiz 8. Sige, check ko na lang yung yung discussion board. Okay.
Okay. Okay, may questions pa ba? Okay. Wala nang questions. G na tayo. Oo. Happy lunch, everyone. Thank you. Tapos may question pa, may message pa
Sorry.
pala. Doc, ask lang po if ipopost ba ang feedback ng LE4?
We'll post it on Friday.
Sa Friday. Yes po. Yun lang. Thank you.
Thank you po.
Thank you po.
Thank you po.
Wait lang. meron pa announcements. For the laboratory tomorrow, okay, so we'll be having the laboratory on all experiments on neurophysiology will be done tomorrow. Okay, assigned. Teka, meron na sa waiting room. Okay, groups. So, nung LE4, ang naunang groups are groups 1 to 8, diba? So this time, this week, we'll be having groups 9 to 16 for this week. Okay, so everything will be done. Okay, experiments on general senses and pain and temperature, experiments on special senses, vision, hearing, taste, and smell, and experiments on reflexes and the motor system. Okay, so lahat yun. Okay, lahat yun gagawin natin. So take a look at your manuals. Okay, there are portions that you have to do at home. Okay, and there are parts that you have to do in the laboratory. So again, groups 9 to 16 of all sections will be performing the laboratory this week. And then next week, we have groups 1 to 8. Okay, so groups 1 to 8 will have their ISP this week. Groups 9 to 16 will have their ISP next week. Okay, malinaw? Have any questions? Okay, so merong question. Release of lab room assignments. Okay, I'll post it in Canvas. Any other questions? Okay, yung question dito is lab room assignments. And we will be posting it in Canvas. May we confirm lang po that there will be 2 separate lab conferences. Okay, please check your schedule. Okay, it's indicated in the schedule that we will be having 2 separate lab conferences. The first will be about general senses and first part of your special senses, which is vision. And then the second part of the laboratory conference will be the second part of special senses, which is hearing, taste, and smell, and reflexes and motor. Did I answer your question? Okay. Yes daw. Doc, yung for experiments done at home, pwede po after lab na lang. Yes, you can also or need po before lab. No. We made it in such a way. We suggested that you do some experiments at home to make sure that you finish. Okay, you finish the experiments. Okay, so pwede po after lab na lang. Yes, you can do it after the lab at home. Not necessarily before the lab. Yes. As long as you finish everything. Welcome. Any other questions? Okay, any other questions? Please make sure you read the procedures, no? The procedures are very simple. Okay, and they are you will be doing this also in the clinics. Okay, most of the procedures. Okay, maski yung simpleng pagpapaamoy ng mga scents, ginagawa yun sa clinics. Okay, so any other questions? To be done at home po, yung naka-indicate lang po ng at home, yes. It's indicated in the lab manual. Please check. Are there any other questions? Parang wala na yatang questions.
Announcement na lang.
For synchronous, ma'am?
Yeah.
Sige, ma'am.
For next week's synchronous session will start at 8:15. Okay sa inyo? There are 2 topics for special senses. Actually more than 2, pero 2 lecturers.
Okay, so we will 1-5 ha, 8:15, hindi 8:50. 8:15.
Yes. 15.
Oo, ma'am, kasi baka may magsabing akala nila 50. Okay, so any other questions? Okay, so if there are no more questions, okay, wala nang questions. Okay, so ito na talaga, pwede na tayo mag-close. We can leave. Thank you. Welcome.
Thank you po, Doc.
You're all welcome.
Thank you, Doc.